Well, thank you, and good morning. Let's see. I want to thank the organizers for the gracious invitation to speak, and congratulations to you all and SVIN for a great conference. Every year or so when I come, it just gets larger and larger, which I think is a reflection of all the excellent work that you and your colleagues are doing and the expanded knowledge in this field. So congratulations to all of you. I have no disclosures relevant to this presentation. So this is the outline. I'm going to spend very few minutes talking about the overall lytic landscape, and then we'll go over some data about Tenecteplase versus TPA, or the proper term now is Alteplase, in the setting of acute ischemic stroke. I'm going to move fairly rapidly since we only have 20 minutes. Obviously, the goal of all of this is to open up the occluded vessel, but there's some challenges here. We have to sort of decide which patients we need to open the vessel in, when to open it, how to open it, and then what to do after the vessel is open, all of which are vexing questions that we may or may not have good answers to. This is a slide that I'm sure many of you have seen many times in the past, showing that time, in fact, is brain. This is from Jeff Saver's analysis of a lot of other studies, showing that per minute of an acute ischemic stroke, you lose almost 2 million neurons a minute. I don't know about your friends, family, and colleagues, but I don't have too many friends, families, or colleagues who can afford to lose 2 million neurons a minute. So time indeed is brain, and we have to open these vessels sooner rather than later. This is a comparison of the pharmacology of the various lytic agents, and if you focus on Tenecteplase towards the top and then Alteplase right below, you can see that the plasma half-life of Tenecteplase is substantially longer than Alteplase, 20 minutes versus somewhere between 4 and 8 minutes. But again, the plasma half-life does not reflect its biologic half-life. And a good example of that is aspirin. Aspirin's half-life in the circulation is really just a few minutes or a few hours, but its biologic effect is much longer than that. Obviously, it inhibits the platelets for 7 to 10 days. And it's the same thing for the lytic agents. Even though its biologic half-life is in the space of a few minutes, as shown here, it can have an anticoagulant or lytic effect that can actually last several hours, which is why people bleed several hours after getting thrombolytic agents. So do not be that deceived by the plasma half-life only being a few minutes. But a point to make is that Tenecteplase is somewhat more fibrin-specific than Alteplase, as you can see by the 4 pluses. And that's one of the advantages, that it will hone in on an acute clot and cause lysis of that versus just roam around anywhere in the circulation trying to look for clots to break up. As you can see here, these are some of the key trials looking at lytic agents in acute ischemic stroke. Obviously, Alteplase has a rich background of studies supporting it, and I think it's fair to say it's the global standard of care for IV utilization, and it is used intraarterially on occasion. Tenecteplase, I'm going to go over some of the key studies coming up, and some of these are very recent studies showing the efficacy and safety of Tenecteplase. The other agents that we somewhat used to talk about, like desmoteplase, pro-urokinase, and urokinase and streptokinase, are really no longer used. I'm not even sure that they're manufactured in the US, so I'm not going to spend much time talking about them. So there are some advantages of Tenecteplase versus Alteplase. It's more clot and fibrin specific, does have a longer half-life, which means it's going to theoretically be more biologic or be biologically active for a bit longer. One of the big advantages is that it can be administered via an IV bolus as opposed to Alteplase, which is a 1-hour infusion, and that makes a huge advantage logistically, time-wise, for drip and ship and things like that. And I think the body of the literature supports the fact that Tenecteplase is as safe, if not perhaps a little bit safer, than Alteplase in the setting of acute ischemic stroke. We'll talk more about this in a minute. There are some advantages of Alteplase, however, versus Tenecteplase. Alteplase in the stroke setting is extremely well studied, numerous phase 3 and even phase 4 trials. There's a broad experience and comfort level among many of the clinicians using Alteplase. It is on most hospital formularies, and I don't think Tenecteplase is, at least not currently, on most hospital formularies. And they do have a program where if you don't use it, or if you get spoiled, or you mix it up and the patient ends up not qualifying, you can return the unused inventory and basically get reimbursed. I'm not sure how widespread that is for Tenecteplase. Obviously, the manufacturer is the same, which is Genentech, but sometimes the policies vary based on the agent and its market share and things like that. Believe it or not, and I know this audience is very much into endovascular therapy, and most of us are great fans of this, but I think it's important to realize that there are some advantages of IV thrombolytic therapy versus endovascular therapy, perhaps not in the United States, but globally. And I think globally, IV thrombolytic therapy is available around the world. Endovascular therapy is not. It can typically only be done in select medical centers with the expertise, the advanced imaging, the IR suites that you've heard about and you will continue to hear about. IV thrombolytic therapy is extremely easy from an infrastructure point of view. You need a CT scan, you need an IV line, and a protocol, and that's basically all you need. Granted, you need some expertise, but it's pretty easy to use. You don't need the complex, expensive infrastructure that you need for endovascular therapy. It can be given rapidly. It can be given in an ambulance or mobile stroke unit, as long as you do some imaging to rule out a bleed, a subdural, brain tumor, things like that. And there's oftentimes no need for the patient to transfer before, during, or after the therapy if the hospital can care for them. However, the major disadvantage is listed on the slide there. It doesn't open the vessel in many of the cases, hence you and your colleagues need to go in and do endovascular therapy to get the clot out. What about the distribution of IV lytic therapy versus endovascular therapy in the United States? Well, currently in the US, we have probably 1,500 primary stroke centers, and they're everywhere. They're in small, medium, and large cities. They're urban and rural areas. And by definition, they can use IV TPA 24/7. Now, some of these PSCs can also do endovascular therapy, but many cannot. If we talk about the 200 or 300 comprehensive stroke centers, again, by definition, they have to have endovascular 24/7. They obviously have IV thrombolysis 24/7, but the distribution is uneven. The vast majority of comprehensive stroke centers are in large cities or urban areas, and again, the patient populations around them is typically very scattered. So many facilities use a drip and ship paradigm or model to treat the patient in the field with IV lytics and then transfer them in for endovascular therapy. However, again, IV lytic therapy is still important to get the ball rolling, and the new AHA guidelines do emphasize get the IV lytics on board, whether or not you're going to do endovascular therapy, and don't wait for the lytics to be done or to see what happened with the IV lytics before you start the ball rolling for endovascular therapy. So let's review some specific studies of Tenecteplase versus Alteplase. The first one is the ATTEST trial. They treated within 4.5 hours of stroke onset. It was IV lytic therapy only. The TNK dose was what we call a low dose, 0.25 milligrams per kilogram, with a maximum dose of 25 milligrams. The Alteplase dose is the standard dose that we know and love, 0.9 milligrams per kilogram, maximum dose of 90. This was a small study. They randomized only 104 patients, and the primary outcome was the percent of the penumbra that was salvaged. So it was really more of an imaging study than a clinical study. This is a study population, and even though the numbers were small, they were fairly evenly matched in terms of door-to-needle time, underlying risk factors, and the type of location of the stroke, the clinical syndrome, as is shown in the bottom there. So again, a small study, but I think pretty well done. What was seen at the end of the day in terms of reperfusion rates? So the light blue is the penumbra, the red is the core, and the green is the final infarct. And you can see just by eyeballing this between Tenecteplase and Alteplase, the results were essentially the same. So Tenecteplase did what it was expected to do: lysis, salvage brain, all good things. If you look at the clinical outcomes in the study, you can see here they were about the same, pretty equivalent, but again, underpowered study to look for any dramatic change or difference in terms of efficacy. And if you look at the bottom in terms of ICH, any ICH, you do see a hint of a change. At the very bottom, you see any ICH was 15% with Tenecteplase versus 27% with Alteplase. So you see a little hint, you see a little beginnings of a signal that perhaps there might be less ICH with Tenecteplase than Alteplase. Wasn't significant, but again, the numbers were small. In 90-day Rankins, again, no dramatic change between TNK and Alteplase. So the conclusions from the ATTEST study was a small study. TNK appeared to work as well as Alteplase. Equal safety, but a slight trend in favor of TNK. TNK obviously is easier to administer with just a quick IV bolus, but we need more data, and we have more data. And the more data came from the NORTEST study published in Lancet a couple years ago. Tenecteplase versus Alteplase, acute ischemic stroke. This was a phase 3 prospective, open label, but blinded endpoint trial. 4.5-hour time window. In this time window, or for this study, they used the higher dose of Tenecteplase, 0.4 milligrams per kilogram, maximum dose of 40 milligrams, and then standard dose of Alteplase. The primary outcome was a modified Rankin of 0 to 1 at 3 months, which has been the primary endpoint for most, but not all, of the Lytic trials. This was a much larger study, okay? Over 1,000 or about 1,000 patients randomized. So again, good statistical power, well-done study with such large numbers. They were matched in terms of gender, demographic factors, stroke versus TIA, so a pretty well-done study. These are the key results. If you look at the top, modified Rankin of 0 to 1 at 3 months, essentially identical, 64 versus 63%. Any ICH at 48 hours, 9% in both groups. Symptomatic ICH, 2 to 3%. So again, pretty equal in terms of efficacy, and then pretty equal in terms of safety. So the conclusions from this study was that TNK and TPA showed equal efficacy and safety. The study did use the high-dose TNK treatment protocol, but it did enroll mostly patients with mild strokes at baseline. No clear advantages with TNK versus TPA, except again the bolus and the lower costs of TNK. This was a new study, came out in 2018, that looked at combining lytics with endovascular therapy. This is the Campbell study. They enroll patients with large artery strokes, the LVOs, who were able to be treated with TNK or TPA within 4.5 hours of symptom onset and had an LVO on the CTA at the initial screen. So they got the lytics, then they were treated with endovascular, and the primary outcome was greater than 50% reperfusion or absence of the clot on the initial angiogram, not the angiogram at the end of the endovascular, but the initial angiogram. So they wanted to see if sort of spiking treatment with IV lytics cleared up the clot and almost alleviated the need for endovascular therapy. This shows the study population was a little bit over 200 patients, pretty well matched for most demographic factors, the site of the vessel occlusion, pretty much the same. So this is the primary efficacy analysis. So if you look at substantial reperfusion at the initial angiogram, this was seen in 22% of the TNK group and only 10% of the Alteplase group. And this difference was statistically significant. Even looking at the adjusted incidence ratios, it ended up being very statistically significant for the efficacy side. And you can see here, functionally independent, which is a modified Rankin of now 0 to 2 at 3 months, 64% with TNK, 51% with Alteplase, just missed statistical significance, but certainly a strong trend in favor of TNK versus Alteplase. And the excellent outcome, 51 versus 43%, again, a trend in favor of TNK versus Alteplase. What about the safety outcomes of this study? So again, death, 10% with TNK, up to 18% with Alteplase. Whoops. And I think this was statistically significant, just made it 0.049. Symptomatic ICH, however, very rare, 1%. Parenchymal hematoma, 6 and 5%, not statistically significant. But certainly an advantage in overall outcomes in terms of death. Death is one of those endpoints that ruins your whole day, right? Yes, indeed. So the conclusions from this study is that patients treated with TNK versus Alteplase before endovascular therapy had better angiographic outcomes, better clinical outcomes, lower mortality. Overall bleeding complications were equal. Again, keep in mind, treatment was started within 4.5 hours of stroke. So this was not a study of wake-up strokes with time windows of 10, 16, 24 hours. And again, these results may not apply to endovascular therapy started at a later date. Now, these are from the brand new AHA acute ischemic stroke guidelines. And I picked out the things that focus on Alteplase and Tenecteplase. And I put it here so you can read it for yourselves. It may be reasonable to choose Tenecteplase, single IV dose with the low-dose regimen, over IV Alteplase in patients without contraindications for IV fibrinolysis who are also eligible to undergo mechanical thrombectomy. And this is a 2B recommendation, which, again, it's reasonable to do that. And then down below, the second TNK recommendation is that TNK administered with a high-dose regimen, 0.4, single IV bolus, has not been proven to be superior or non-inferior to Alteplase, but might be considered as an alternative to Alteplase in patients with minor neurologic impairment and no major intracranial occlusion. And they give it a 2B recommendation, and both of these are new recommendations. So basically what the guidelines are saying is that, yeah, it's something reasonable to do that, you might consider doing. So the overall conclusions are that Tenecteplase is now included in some guidelines, but again, with limited indications. Tenecteplase does have some practical and financial advantages over Alteplase. Its widespread adoption, in my opinion, is likely several years away, but I don't see any real particular barriers. I think future studies in this realm could be looking at expanding the treatment time window. And as I'm sure many of you are aware, there are just those types of studies going on to expand the IV lytic time window, use advanced imaging criteria for patient selection, begin the treatment in the ambulance before hospital arrival, again, if you have a mobile stroke unit and can rule out bleeding, continue with lytics and EVT as combined therapy, and then the very exciting realm, which again, there are studies being launched, is again trying to combine neuroprotection agents with the protocol. Thank you all very much for the invitation to speak to you today.
Thank you, Mark. Thank you for staying on time. So we'll ask all speakers to remain here nearby, as we have ample time to question and answer session at the end of all presentations. So go ahead.
Our next speaker, Dr. Tudor Jovin, and his talk today is going to be on role in LVO selection and clinical trials with the use of RAPID. He's joining us from Cooper University in New Jersey. Dr. Jovin.
All right. Good morning, Tudor. All right. So is Raul here? Our next speaker, Dr. Noguer. All right. Well, that's an interesting twist. We'll give them a couple of minutes. And is Brinjiki is here? Yeah. Okay. So we'll ask our last speaker to come out right now. And I'm going to send the SWAT team to find out where the other two speakers are. Right. All right. Thank you.
I guess I just gotta get my slides up.
He's going to be talking to us today about artificial intelligence, future workflows for diagnostic neuroradiology.
Let's see here. All right, sounds good.